Hello, my name is Yeleni Sergio de Armas. Today I'll be presenting a case about an unusual presentation of acute coronary syndrome. Spontaneous coronary artery dissection is a non-iatrogenic and non-traumatic separation of the coronary arterial wall and is a rare cause of acute myocardial infarction. It is the cause of acute coronary syndrome in 0.1 to 4% of cases in the general population, although has been reported to account for almost a quarter of the cases of ACS in women less than 50 years old. The pathophysiology of Scad is not fully understood. It's been proposed that an intimal tear or bleeding of the vasa vasorum with intramedullary hemorrhage might result in the formation of a false lumen filled with intramural hematoma. False lumen expands under pressure by an enlarging hematoma leading to luminal invasion followed by myocardial ischemia and infarction. It is also thought that coronary artery tertiary may be a marker for or a mechanism for Scad. However, it is also associated with extracoronary vasculopathy, such as fibromuscular dysplasia, in which the case the tertiary may be a manifestation of the underlying predisposing vasculopathy. Most cases of Scad are associated with a predisposing arterial disease. However, up to 20% of the cases are found to be idiopathic. In addition, most patients have no risk factors for coronary artery disease. We present a 51-year-old female with no significant past medical history who was brought to the emergency department with a sudden onset substernal chest pain. It started approximately 2 hours ago. Pain began at rest and it was described as pressure-like, radiating to the left arm, 8 out of 10 in intensity, and it was associated with diaphoresis and abdominal discomfort. Upon arrival of EMS, patient received aspirin, sublingual nitroglycerin, which only mildly alleviated her pain. Patient was transferred to the hospital with EKG showed ST segment elevations in the precordial leads with inferior reciprocal changes. As you can see in our EKG picture over here, we have the ST segment elevations and the reciprocal changes. Cardiac alert was called and the patient was subsequently taken for cardiac catheterization. Coronary angiography reveals Scad from the proximal left anterior descending artery into major marginal branch. Over here you could look and see the dissection in this left coronary angiography images. No further intervention was performed and the patient was started on anticoagulation, aspirin, clopidogrel, and beta blocker. She remained hemodynamically stable and chest pain subsided within the next 24 hours. She was discharged home after 48 hours on dual antiplatelet therapy and beta blocker. There is lack of randomized trials comparing medical therapy to revascularization strategies. Observational data shows that when repeat angiography is performed, 70 to 97% of the patients were conservatively managed to display angiographic healing of the Scad lesion. In addition, PCI is often challenging due to the fragility of the vessel wall. Any instrumentation can spread the dissection and occlude the side branches. Therefore, conservative treatment is recommended in most cases and revascularization is considered in patients exhibiting active myocardial ischemia, hemodynamic instability, or left main dissection. Coronary artery bypass grafting surgery should be reserved for patients with left main or multivessel dissection, especially in the setting of hemodynamic compromise. While uncommon, Scad should be considered in a young patient, particularly young women without prior history of coronary artery disease or risk factors, presenting with an acute myocardial infarction. Thank you so much for your attention. Have a good day.